All right, airway and breathing course. Of course, Johnny and Roy had the EOA or the EGTA, but we've got some different supraglottic airways now. This one's on the Combitube. Won't spend a lot of time on this. It's covered very, very well, very thoroughly in the accompanying Moodle lesson. And you really ought to hold one of these in your hand and just be able to name all the parts. But unlike the King, there are two separate ports for the two separate cuffs on the Combitube. And basically the Combitube is an EOA, an old esophageal airway, and an ET tube kind of stuck together. The idea being you get the benefits of both. Some would say you got the benefits of neither, but it is a valuable tool. We've used it for many years. We just felt like the King had something better to offer, and we've kind of moved away from the Combitube here in most of our system. But the same as with the King, it can't have a gag reflex and shouldn't have any esophageal damage. Watch for those guys with the liver disease and having those esophageal varices. I don't know how you're going to know that you've got esophageal varices unless you nick one of them, and then the bright red copious bleeding will certainly cue you in. But esophageal damage and gag reflex. And then we always talked about size on these too, because there's two sorts of Combitube out there in the world. There's the regular Combitube and the Combitube SA for small adult. There's two different sizes, a 41 French and a 37 French. And so you can have the Combitube be too big to where the holes are too far down, you're not getting good ventilation. Your technique is a neutral position. We're not going to do any thyroid pressure, and we don't do cricoid pressure. We're going to lift that mandible up. The DL scope works good for that as well. And insert this to the teeth marks. There are teeth marks on the Combitube. You don't go all the way in to where just the hubs are sticking out, the connector's just sticking out. You go into the teeth mark. Inflate your number one, which is usually blue cuff, to whatever it says on the pilot balloon. I believe it's 100 in the normal Combitube, the 41 French, and it's like 80 or 85 in the Combitube SA. So do number one first, then number two. Again, number two will tell you how much air to put in there. It's 20 cc's or 15 cc's or 12 cc's or something like that. It says so right there on the pilot balloon. Then, so you've inflated, and then you ventilate. Ventilate the number one blue and look for chest rise. And you usually will get it. If you don't, switch over to that number two and ventilate. It may be that you have accidentally placed the tip of the Combitube through the cords, and you have an ET, intubation, as long as you use that number two port. That's possible, but it's really uncommon. So if you ventilate and you've got no chest rise with the number two, then you deflate both those cuffs and pull it back out a little bit because it's just too long for the patient. And then reinflate the cuff. So on the King, you're going to drag it back and ventilate without dropping the cuffs. On the Combitube, you need to deflate the cuffs and then remove it slightly and ventilate it. Troubleshooting stuff. Like I just said, if you ventilate to that number one port and you don't get chest rise, it might be in the trachea, but it's also just as likely, if not more likely, that the Combitube is too deep. Especially if you have a shorter patient and you're using that 41 French full-size big boy Combitube, you're probably a little too deep. So if you ventilate to number one and it doesn't produce chest rise, go to number two. If that doesn't work, then you're into this backing it up a little bit because it's too deep. But if you get amazingly lucky and the number two port produces chest rise, well, congratulations. You've blindly inserted a Combitube into the trachea. You have a de facto ET tube. Although as big as that Combitube tip is, that's going to be a heck of a feat to get it into the trachea. If neither of the blue or the white works and it's because you're too deep, back it up a little bit, deflate both cuffs, back it up a little bit, reinflate, and get back on that number one and ventilate there. But don't be messing around too much with this thing. The patient needs oxygenation and ventilation, not some sort of tube in their airway. It's not about that, and so you just have to be very disciplined and understand your device. So that's the Combitube.